Thanks, Jeremy. Hi, everybody. Just going to switch my video off again to save everyone's bandwidth. I'm going to be speaking about leprosy, particularly in South Africa, and Jeremy's kindly allowed me to speak to you about the Gorgas DTMNH for a few minutes as well. So we start with a little trip down memory lane just to show you all of us in our young days. This was our ID class back in 2016, all of the ID fellows in the country, with some familiar faces in there. And these were my colleagues at Grooteskier as well. So all of these experiences had led me to want to do a bit more tropical medicine before I came back to work at Barra. And so this is how I ended up in Peru for 9 weeks in 2018, doing the Gorgas course. Uh, and just a few quick facts about Peru, very similar to South Africa, middle income country, high TB prevalence, and a lot of inequity as well. So a lot of very rich and a lot of very poor. This is the suburb, for instance, that many of the participants on the course stayed at. So very beautiful, nice views of the Pacific. But the hospitals were actually very similar to what we see. Okay, so the Gorgas course is run by the University of Peru, Cayetano, and you can see a photo here. I don't know if anyone wants to type in the chat what this parasite is. Clue, named after the university. It was actually the taxonomy and epidemiology work was done there in the early 90s. So I can't see the chat. I don't know if anyone's typed anything in yet.
Not yet, but we'll see.
Okay. Okay. Anyway, it's Cyclospora cayatenensis. All right. So a common cause of traveler's diarrhea. Another fun fact is if anyone who attends the Gorgas course gets diarrhea, they do assess you and they check to see if you have acquired this parasite. The course was mainly based in Lima, Peru, the capital, but also had field trips to Cusco and also Iquitos, which is here in the Peruvian Amazon. So it was not all holiday or fun and games, quite the opposite, in fact, quite a well-structured program. Um, Mornings and afternoons were basically lectures with some of the greats. Um, this is David Friedman, for those who are familiar with travel medicine. He was the past director of the Gorgas course, and that's Germán Hinostroza, the current director, both of them based at UAB in the US. And what was interesting about Gorgas, and still is interesting, is the combination of clinical rounds with lectures and with dedicated laboratory time. So quite a well-structured program with a rotation to different hospitals doing different ward rounds, including dermatology, neurology, ophthalmology, and pediatrics. And this was my group that I spent, just do a laser pointer here. This was my clinical group, actually, that I spent most of my time with. And these were our laboratory practicals. So if anyone is familiar with snakes and toxicology, that's Prof. David Worrell from Oxford, who was an invited lecturer, came to also lecture us. He did the rabies talk, snake bites, all kinds of cool things. And this is one of our lab pracs, and you can't see them here, but these are actually the vectors for trypanosomiasis, for Chagas. So those are the triatomine bugs. So we got to spend quite a bit of time in the lab looking at all of these things. And this was our class. So there were 38 people. They take a maximum of 40 people on each course, together with the lecturers, also the medical students from the university who assist. They interpret for you when you see patients and help you get from place to place. What was really nice was during the trip to Cusco, we had a free day where we could go to Machu Picchu if we wanted. So that was pretty cool. All right. So if you want to learn more about the Gorgas course, have a look at the links. Um, there is a diploma course, which is what I did, which is the 9-week DTM&H. And then there's also an expert course for those who've already done the diploma course anywhere. And if you're an ID specialist, you can do this as well. So What the advanced course is a 2-week specific program for ID trained specialists and people who've already done a DTM&H. And very interesting, also quite competitive, quite difficult to get into. So have a look at it and see if you're interested. Okay, now to the actual reason that I am presenting. Um, I'm going to talk to you about leprosy. And the reason that I spoke about the DTM&H was really because this is where I got to see patients with leprosy and interact with experts who had been managing these patients for years and years. And what I've learned is a clinical approach from them, also colleagues locally. So this is Pedro Legua. He is one of the founding sort of lecturers on the Gorgas course, an expert clinician, also a passionate teacher. And this is Pedro in 2018 in his 60s. He's now 73 and still teaching. And this is him when he was much younger in his studies with a patient with leprosy. Okay, so just very briefly, leprosy is considered a neglected tropical disease. It's also called Hansen's disease, named after a physician called Hansen. Historically, I think as we all know, associated with quite a lot of stigma, quite a lot of misunderstanding around the disease, leading to people being segregated and put into leper colonies. The majority of cases are in developing countries, with India and Brazil having the highest amount of reported new cases per year. The disease is more common in males, and this is also true for South Africa, where only about just under 30% of our cases are female. Risk factors for getting leprosy or developing disease from leprosy are older age. There are some genetic issues as well associated, and immunological risk factors. Although I do need to say that it's quite different from tuberculosis. It's not as common in people with HIV or post-transplant. In fact, if someone develops leprosy in those populations, there are often case reports. But we do know that you have to have some degree of immune dysfunction to develop leprosy. The most important risk factor is extensive contact. You need to have 5 to 8, you become 5 to 8 more times more likely to develop the disease if you are close personal contact of someone with leprosy. We don't understand transmission very well, but it's most likely through the upper respiratory tract. And I will show you the classification just now, but lepromatous leprosy is far more infectious than tuberculoid. What we do know is that it's not transmitted sexually or through casual contact. So this is how we know that there are genetic factors associated with an increased risk of leprosy. There are genes that have been implicated in increased susceptibility, and also in studies looking at monozygotic versus dizygotic twins, leprosy is more common in monozygotic twins. Now, looking at Africa and the epidemiology of the disease in Africa, so of the 21,000 new cases globally, of the 182,000 cases globally in 2023, only 11.5% of those were from the African region. And within Africa, there are 6 countries that have been highlighted as sort of highly endemic comparatively, reporting more than 1,000 new cases per year. And these are listed on the slide. In South Africa, we reported between 11 and 100 new cases in 2023. So this is important to note because even though leprosy is less common in South Africa, if you see a patient from one of these higher endemic countries, you need to be aware that they may have leprosy and you need to have a higher index of suspicion. So what about our epidemiology? Actually, we have met the target for leprosy elimination because the prevalence of disease is less than 1 per 10,000 population, although we still do have cases of active disease. Our estimated prevalence in 2011, so this was very long ago, but this was the last count I could find, was around 3,000. And at Barra in 2020, we had 8 to 10 active leprosy cases at the Barra Dermatology Outpatient Leprosy Clinic. And around 70% of those were lepromatous. So Jabu Ketli wrote this article. She's the head of dermatology at Baragwanath Hospital, based on basically the epidemiology of leprosy at her clinic. What patients, what their risk factors were, what their outcomes were. It's worth a read. I will share a link to it at the end as well. In terms of causative agents, there are two organisms that have been identified as causing leprosy. So Mycobacterium leprae and Mycobacterium lepromatosis. So lepromatosis is a bit of a new kid on the block. Was really identified in 2008 and sequenced and found to be distinct from leprae. And geographically, it is limited to Mexico and parts of the Caribbean. Causes quite a severe form of leprosy called a lepra bonita. So by and large, the majority of cases are caused by Mycobacterium leprae. Um, they can be indistinguishable clinically, though. They're both intracellular, acid-fast, aerobic, rod-shaped mycobacteria, and they're obligately intracellular. So the cells that they infect are Schwann cells and histiocytes. And importantly, they can't actually be cultured in a routine lab. For research purposes, they're often cultured in mice and armadillo foot pads, but that's not of diagnostic use. Very slow growing organism, divides every 12 to 14 days. Like I mentioned, has a tropism for nerves, and just an interesting story. And the poor armadillos have been blamed for transmitting leprosy, but actually they acquired the organism from early American explorers. Um, the transmission was sustained in the armadillo population, and then they transmitted it back to humans. So it has been called zoonotic, but they actually got it from us in the first place. The mechanism of transmission of leprosy and potential environmental reservoirs are not fully understood. There are multiple hypotheses. It's an ongoing area of research at the moment. And this disease has a really long incubation period. So patients with tuberculoid leprosy, generally from infection to onset of symptoms, is 2 to 4 years. And with lepromatous, even longer, 5 to 10 years. In terms of clinical presentation, there can be early examination findings involving skin lesions, also altered sensation, usually in areas where there are skin lesions present already. Patients can also present with painless wounds or burns, um, having sustained injuries because of the lack of sensation. Also, they can have these tender, enlarged peripheral nerves. Another presentation can be neuropathy on its own. So about 5% of cases of leprosy present with pure neuropathy without any skin lesions or any other findings. Another presentation may be ophthalmic injury from iritis or keratitis. So usually when the first division of cranial nerve 5 is involved, there can be a lack of corneal sensation, a lack of your corneal or a diminished corneal reflex, and patients can develop injuries as well. In terms of the classification of leprosy, there are two classifications. There's Ridley-Jopling, and there's also WHO. So this is an image from Up to Date that actually, sorry, that actually depicts both of them. So at the bottom, this is the WHO classification. So PB is paucibacillary, meaning few bacilli, and MB is multibacillary, meaning multiple bacilli. Okay, and here we can see this red line indicates a higher concentration of bacilli, whereas the blue line here indicates higher cell-mediated immunity, and on this end, low cell-mediated immunity. So if we look at that, we can see that leads us to the Ridley-Jopling classification. Okay, so before we get there, before we get there, a patient can be infected and have no disease or have indeterminate disease where it hasn't actually evolved yet to fall into one of these classifications here. So in terms of the classifications, we have at the one end of the spectrum where there's high cell-mediated immunity and low bacillary load, tuberculoid disease. At the other, it's lepromatous disease. So lepromatous would be high AFB, low cell-mediated immunity. And in between, we have these borderline subtypes. So in the middle, is borderline, borderline, or mid borderline. Between borderline, borderline, and tuberculoid borderline, we have borderline tuberculoid. Between borderline, borderline, and lepromatous, we have borderline lepromatous. Now, I know it sounds a little bit odd. What does this mean? I'm going to show it to you now. It has clinical relevance, the differentiation between them. What's important to note here is that these borderline categories are also sort of designated unstable immunity. So that's going to have implications down the line for one of the complications of leprosy, which are the reactions, which we're going to get to just now. So in terms of the WHO classification, paucibacillary and multibacillary. Paucibacillary would be a patient who has 1 to 5 skin lesions and without demonstrated bacilli in a skin smear. Multibacillary is a case that has more than 5 skin lesions or has nerve involvement, including pure neuritis, and or has the presence of bacilli in a slit skin smear, irrespective of the number of skin lesions. So if you have any bacilli in a slit skin smear, you have multibacillary disease. This table is taken from Jabu's paper, again, summarizing the same thing. Okay, and another table from her paper, which is quite useful, is a summary of the clinical features of leprosy based on Ridley Jopling. So I'm going to show you a few borrowed clinical photos from my colleagues in Peru, looking at the different subtypes of leprosy. So we're going to go through them one by one. So in terms of tuberculoid leprosy, remember this is the left end of the spectrum, high cell-mediated immunity, paucibacillary disease. What we can see is that there are is usually a single lesion, well-defined, hypopigmented or erythematous, can occur in a patch or a plaque. Usually the skin is hairless and dry because of involvement of the autonomic nervous system, and there may be enlarged nerves, 1 or 2. Sensation over the lesions, there's usually no sensation. So in the cases of high cell-mediated immunity, usually sensation is lost very early on. Few bacilli on a smear, immunity is high. I wanted to show you the contrast between these two images as well, because you can see that it's very difficult to see and looks very different in a patient with pigmented skin compared to a patient with lighter skin. So this is a bit easier to see, very discreet, very erythematous, whereas here it's a bit more subtle, hypopigmented, single patch. Okay, in terms of the borderline tuberculoid variant, we can see that there are also few lesions, but more than one. So usually around four or more. They're well defined, so they have this nice defined edge, but they can have satellite lesions, which you can see on here. It can be macules or plaques. The lesions can be of varying sizes. And in terms of nerve involvement, there are few nerves involved, and they can be asymmetrically enlarged. Sensation is usually reduced. They may or may not have bacilli on a skin smear. And this is one of the unstable immune variants. This is another photo of borderline tuberculoid, just to show you in more pigmented skin how this could look. This is the same patient. So a couple of lesions, up to 4, could be more, some satellite lesions, and you can see that they are actually very well defined. So you can see the border of them. Okay, borderline. So borderline, borderline, or mid-borderline. So these lesions, there are numerous lesions, but what is important is that they're distinct and discrete. So they can be counted. They've got varying shapes. So you can see that this is a large plaque-like lesion with lots of other nodules surrounding it. In terms of nerve enlargement, they may be symmetrically enlarged and multiple nerves may be involved. Um, the bacilli may or may not be reduced, may or may not be seen. And this is also a very unstable immune category, right? Prone to reactions, type 1 reactions. Okay, so borderline lepromatous leprosy, we can see that also multiple lesions, they become a bit more difficult to count separately because their borders are indistinct. They're quite ill-defined borders. It almost looks like they're coalescing. Very erythematous. There's a combination of plaques, patches, nodules. Um, in terms of nerve enlargement, there may be many nerves involved and they may be symmetrically enlarged again. Sensation may or may not be reduced, and the number of AFBs are usually numerous. Okay, and now the far end of the spectrum, this is lepromatous leprosy. And there are multiple clinical features of interest in this case, but what I would like you to note, firstly, from the skin lesions, is that they're usually symmetrical. Um, it's it's difficult to find a border. It almost looks as though the skin is infiltrated in this patient's case. And what we can see is almost a thickening and shiny skin. And this results from infiltration of the dermis with mycobacteria. Um, what we can see, and I don't know if anyone wants to type in the chat what they can see, but these are usually classical clinical features of lepromatous leprosy. We see these thickened and enlarged earlobes. Uh, we see the sort of loss of definition of the skin in the face with the accentuation of these creases. So this patient would have what we call leonine faces, lion-like, because of this accentuation of the creases. I'll show you a better picture of his face just now to see the other features that he has. So again, this thick infiltration of his dermis with these bacilli. So you can see the skin. It's difficult to see discrete lesions, but they are visible. But his entire, all of his skin is thickened and erythematous. Okay. What we can see here is an enlarged ulnar nerve. There are associated skin changes as well, nodules, hypopigmentation, and this is quite severe deformity of the hands following loss of neurological function in those peripheral nerves. Um, okay, and this is the close-up of the patient's face, a patient with lepromatous leprosy. And what we can see is loss of the outer third of eyebrows. You can't see, I've blocked their eyes, but they don't have eyelashes either. We call that madarosis. So ciliary and superciliary madarosis. And you can see quite nicely here the thickening of the skin on the face and these accentuated lines as well. Even here as well in this image on the right. There's also a saddle nose deformity from loss of cartilage. So interestingly, lepromatous leprosy is the only variant that has mucosal involvement and causes damage to cartilage. Patients can also present with epistaxis. This is another presentation of lepromatous leprosy. Okay, so in terms of diagnosis, uh, this is a very wordy slide. I do apologize, but the bottom line is in most cases, in most areas where leprosy is endemic, it is a clinical diagnosis and it can be confirmed by a slit skin smear. Positive skin biopsy is ideally the gold standard, but is not always available everywhere, especially in areas where leprosy is highly endemic. So there are diagnostic criteria. And a case of leprosy is defined as someone who has one or more of the following. So if you've got a hypopigmented or reddish skin lesion with definitive loss of sensation, that's quite unique to leprosy, and that is why it counts as diagnostic criteria. If there's damage to peripheral nerves demonstrated by loss of sensation or weakness because of motor involvement of the nerve to the muscles of the hands, feet, or face, So lep leprosy has a predisposition to affect peripheral nerves, like we've said earlier, or if there's a skin smear positive for AFB or a positive biopsy. Okay, there are other laboratory assays that can be used. However, they're not as widely available and not really recommended. They are mainly used in a research setting. PCR is available in some high resource settings, but these kits do lack standardization. So ideally, it's a clinical diagnosis plus a skin biopsy or slit skin smears. There's a test called the Lepromin test that consists of injecting M. leprae antigens into a person's skin, waiting 4 weeks, and then checking to see if a granuloma has developed. This doesn't prove infection, and it's not a useful test in terms of um, indicating exposure or disease. So it's not useful for diagnosis. In terms of a slit skin smear, there are guidelines available for how to do this. They're available on the WHO website, and really skin smears are quite useful. So they're used initially for diagnosis when there's clinical suspicion of disease. They're also used to monitor treatment in patients with lepromatous leprosy because you want to see a change from multibacillary to absent bacilli. That's how you evaluate whether a patient is responding to treatment. It's also useful in cases where you suspect a relapse after completion of treatment. So this, I'm not going to go into this, but these are the sites that can be that where the skin smears can be done, and where they're preferred to be done. So both earlobes, knees, elbows, wherever you see a suspicious skin patch, usually above the skin on the forehead, medial border of the eyebrows, and any previously positive sites. And this is the process for how to do it. Okay, in terms of a biopsy, this is useful for classifying leprosy cases because we can tell based on what cells are involved, whether they're nice granulomas that are formed and paucibacillary disease or whether it's multibacillary disease and mainly foamy macrophages. You can tell which end of the spectrum patient is presenting and direct treatment appropriately. Okay, so in terms of complications of leprosy, there's neuropathy and disability, which are the main consequences of late and inappropriate treatment. There are also adverse effects of the treatment itself and these leprosy reactions that I'm going to tell you about. So patients can be affected before treatment, during treatment, and after treatment. Um, what is um, what is hopeful is that leprosy is curable almost all the time, but you need to diagnose it early and you need to treat it properly. And in South Africa, where we have a very low prevalence, we need to recognize the early signs and symptoms, examine household contacts and close contacts, because remember, that's the most important risk factor for developing leprosy, and increase community awareness. So in terms of the pathogenesis of peripheral nerve damage, it's really immune mediated. Um, the bacteria, the mycobacteria have a preferential sort of affinity for infecting non-myelinated Schwann cells. They tend to proliferate in them, which causes, which allows the bacteria to survive and disseminate. When they do infect myelinated Schwann cells, there's a process that gets activated that leads to demyelination and neurodegeneration. Um, and in parallel to all of this is an inflammatory reaction that also in turn leads to neurodegeneration through macrophage activation. So in terms of the peripheral nerves that are affected and how to examine them, um, this is a nice graphic just showing you which are the most common nerves that get affected or can be enlarged and inflamed in patients with leprosy. What needs to be done is you need to actually palpate them for thickness and tenderness, and also do a neurological exam on the patient to evaluate motor and sensory function. The most common sensory loss involves temperature and light touch. Um, and in patients with tuberculoid disease, so on the far left end of the spectrum, people with a high cell-mediated immunity, um, the sensory and motor loss of the nerves tends to happen in the distribution of the skin lesion. Because remember, those are the patients that have very few skin lesions. So their nerve involvement tends to follow that. In patients that have the other end of the spectrum, Leprosy disease, multibacillary, the nerve damage can be more generalized. Multiple nerves can be affected at the same time, and they're usually symmetrically involved. And these are the deformities that can sort of take place after, depending on which nerve is involved. Okay, so in terms of treatment, our South African guidelines have we don't have specific South African guidelines since 2011, but what has changed is that we have followed the US guidelines, which I will show you just now. But according to our old guidelines, this is how leprosy used to be treated. So treatment is based on the WHO classification of leprosy. So paucibacillary leprosy, meaning 1 to 5 skin lesions, multibacillary leprosy, more than 5 skin lesions. Okay, so what was given was monthly rifampicin and daily dapsone for 6 months for paucibacillary disease. And for multibacillary disease, the treatment was extended to 12 months. And in addition, clofazimine was given daily. Okay, so these are what the multi-drug treatment packs look like. They're provided by the WHO. In South Africa, they get distributed by an organization called the Leprosy Mission, which is an NGO that has a specific interest in leprosy and the treatment of leprosy. So the treatment has become fairly easy to take because it is provided. And this is what the WHO recommends as of 2018. So they recommend clofazimine daily as well for paucibacillary disease. So the treatment regimens are actually the same in paucibacillary and multibacillary. The difference is the duration of treatment. For pauci, it's 6 months, and for multibacillary, a year. Now, we tend to follow the US National Hansen's Disease Program. It's a long name, treatment recommendations. And what they suggest is daily rifampicin and daily dapsone for paucibacillary disease for 12 months, so a longer duration of treatment. And for multibacillary leprosy, daily rifampicin, daily dapsone, and daily clofazimine for 2 years. So what we use in or what is being done at Barra and I think the rest of the country is to usually follow the US guidelines in terms of duration, and treatment is usually individualized. So when you stop treatment can be based on a combination of smears, and when they become negative, like I said at the beginning, most of the cases we see in South Africa are actually leprosy, and also clinical resolution of the skin lesions. So for both paucibacillary and multibacillary, it's daily clofazimine, dapsone, and rifampicin. Rifampicin gets changed to monthly when the smears become negative in multibacillary disease. So in terms of drug resistance, it does exist. It's very uncommon, but it does exist in areas that are highly endemic with leprosy. And the main drugs that are implicated are rifampicin and ofloxacin. And there are specific second-line regimens that are recommended. These patients become very difficult to treat, though, and it's recommended that they are seen in a specialist facility with a lot of experience with leprosy treatment. Unfortunately, there isn't much evidence for, the use of second-line regimens. They're based on expert opinion. It's not known what the outcomes are in these cases. So it's something to consider if a patient isn't responding to treatment. But just to say that most cases, especially in South Africa, are drug susceptible. In terms of prevention of leprosy, BCG vaccination does have some protection against leprosy disease, particularly in household contacts and kids that live close to people who have adults who have leprosy. So there was a randomized controlled trial that found that single dose rifampicin as a preventive treatment for leprosy contacts reduced the risk of leprosy. The most benefit was seen after 2 years, where it was a 57% reduction and 30% reduction after 5 to 6 years. So it is something to consider if you do see a patient who has active leprosy disease and after leprosy and TB have been excluded in their close contacts and there are no other contraindications. Okay, now the immune reactions. Unfortunately, this is sort of one of the worst complications that a patient with leprosy faces. These are unpredictable immunological reactions that are systemic. They can be severe or mild. They can relapse and remit. And it's difficult to compare it to iris, even though it is tempting, because these reactions can be the patient's presenting problem, even before treatment is started. So it can happen before treatment, during treatment, or even months to years after treatment is completed. And there are two types of reactions. So there's a type 1 reaction, which is also called a reversal reaction. And this occurs in those patients with the borderline disease. So those three categories in the Ridley-Joplin classification in the middle, mid-borderline, lepromatous borderline, and tuberculoid borderline. It's a type 4 hypersensitivity reaction, cell-mediated, and the treatment is usually high-dose steroids that can be tapered, and clofazimine can be used as well. The type 2 reactions are also called erythema nodosum leprosum, ENL, and these occur really in the patients with multibacillary disease. So in those with lepromatous leprosy or borderline lepromatous disease. And it's a type 3 hypersensitivity reaction, so immune complex mediated. And the treatment here is usually high-dose steroids or thalidomide, which has very good outcomes in most of them. So just to show you what they can look like, this is an example of on the right, a severe type 1 reaction. What's helpful is to compare photos of the reaction with the lesions and what they looked like previously, and you see a distinct difference. So they're usually red, raised, um, they can be ulcerating, they can have new sensory impairment or new motor impairment. So essentially it's a worsening of the lesions after apparent cure. And in a type 2 reaction, they can be really debilitating. Um, these can be systemic reactions, can have multiple organ involvement. In some patients, their reticuloendothelial system can be involved, liver, spleen, bone marrow, even testes. They can have severe edema. Um, it's usually related to these new tender nodules. They can be subcutaneous and also new enlargement of the nerves. So this is a patient who's got a type 2 reaction. You can see these new nodules, and they tend to come up quite quickly and in crops, so all together. So that is one sort of clinical differentiator from in terms of distinguishing a ENL or type 2 reaction from relapse. Okay, so like I said, these type 2 reactions can be mild or severe. They can also be intermittent or continuous. So with intermittent type 2 reactions, these attacks usually last about 2 weeks, and then it's followed by a reaction-free period of a month or two. And they can usually have systemic symptoms, so fever, malaise. The lesions can ulcerate, nerves become painful, nerve function might occur. and they can be continuous, and these are extremely difficult to treat as well. So these are patients that where there is no reaction-free period. These reactions are severe. These patients often need hospital admission, continuous treatment with corticosteroids for at least 3 months. And despite all of this, there might still be a poor response to treatment, which is why thalidomide then becomes an option for treating these cases. So this is a patient that we saw in Peru who presented with a type 2 reaction. He developed this new crop of subcutaneous nodules that you can see quite nicely. He's got them everywhere, but here they're quite nice to see, quite visible. And after 2 weeks of steroids and thalidomide, he had a good response. So response to treatment is also a good way to differentiate between relapse and a reaction, response to immunosuppressive therapy. Which brings me to the slide. So it can be difficult to differentiate reactions from relapse. But really what's in red is important. The ENL nodules tend to develop suddenly in crops, and they're usually quite painful. So this is in contrast to the nodules that you see in lepromatous leprosy that develop insidiously over time. Um, in terms of the type 1 reactions in porcibacillary disease, this can be quite difficult. And in these patients, a biopsy may help, but it might not. So in these cases, this is where you can treat as though it is a reaction. So you can offer a test, um, you can offer a challenge with corticosteroids for about 2 weeks to see if there's any therapeutic response. If there is a therapeutic response and the lesions are improving, then it's a reaction, not relapse. In relapse, the lesions would be unaffected by any corticosteroid therapy. Okay, so for more info, have a look at these sources. I'd mentioned Jabun Kehli's paper describing her experience with leprosy at Barra. A group in KZN has also published 20-year retrospective study on the outcomes of their patients. And there are WHO guidelines and the US Hansen's disease guidelines. And that's it. Thank you.
Cool. Thanks so much. Really nice overview, and some great photos. Really, really helps a lot. Um, just going to go through some of the questions which have cropped up. Some people have been messaging and things. One in the chat there is asking about BCG protection, and any differences between leprosy and TB in terms of the protection that BCG offers.
Ooh, I can't give you specific figures in terms of efficacy. All I can say is that it is recommended. It is a WHO recommendation. Um, I think given the fact that there aren't many other options and there isn't a specific vaccine directed against leprosy, the benefit is greater than the harm. So, but sorry, beyond that, I can't give you any figures or quote any trials that have been done.
Sure. No, it's probably not out there, to be honest with this
Yeah.
level of evidence. Um, And then someone's asking about the RIF monthly dose. So I see it was given, it's daily, but then monthly if it's with prednisone. Is that because of the drug interactions with prednisone, or do you know why it shifted to monthly if you're taking prednisone?
It doesn't really make sense to me to give it like sort of less frequently if there is prednisone, but I think that that is the understanding is that it's going to be subtherapeutic if or the prednisone it's going to make the prednisone subtherapeutic, I suppose. So yeah, that
Mm.
makes sense. I think that is the reasoning behind it.
Yeah,
It's
yeah,
not evidence-based though, just to say that is based on like sort of experience at the Barra site that sees probably the most leprosy patients, I would imagine.
yeah, I'm sure.
Sorry,
Um,
yes, yes. So I think to answer your question, I think yes, I think it is a pharmacological reason, the kinetic
yeah,
issues.
yeah, makes sense. And then I guess the one other interesting thing, which is always fascinates me, is that the effect of HIV on leprosy appears to be very mild, and there's one or two, there's somewhat more reversal reactions in some cases, but really, we haven't seen a huge, 100-fold increase in leprosy cases with HIV or any even really even shifting between the forms, which is fascinating. And not sure I understand. I'm not sure anyone understands it, but I think we can at least be glad that we've dodged the bullet of HIV with leprosy. It's still pretty rare as diagnoses go, whereas every other mycobacterial infection is like 100-fold. So
I think
I don't know if you had any particular thoughts
I
on it.
think it's because we don't have that many armadillos, Jeremy.
Yes, so true.
Um,
Um, and
I see Steele's written something as
yes,
well.
yeah, yeah. So she's saying leprosy is a difficult diagnosis, although it's uncommon. She's sure we're missing cases. Any
Yeah.
suggestions about the diagnosis versus other causes of plaques and nodules? Anything that would tip you off to leprosy?
Oh, so this is something I actually didn't touch on in the presentation. There's a wide differential diagnosis. Any dermatologists in the meeting would be able to add to this, but for each one of those categories of leprosy, there's a wide differential diagnosis for for other diseases and quite a few non-infectious causes as well. So I think ultimately, Lucille, I feel it would come down to a skin biopsy, like a high suspicion for disease with a skin biopsy, requesting the right stains. And I think that's kind of what our issue is with most infectious diseases is not getting the right tissue and not sending it for all the right tests. So what we need to advocate for is skin biopsies being sent for both histology but also for culture. So bacterial and fungal culture. And because those would be your other big differentials. Um, Fungal causes, bacterial causes. Um, and in terms of the stains, I mean, Azil Nielsen would obviously, I mean, any sort of acid fast stain would be great, although a fight stain would be best in these patients if you're suspecting leprosy. Um, so yeah, it's just difficult because we have such limited access outside of the major centers to histopathology. Maybe better training with slit skin smears and cytology and sort of, the using microscopy to identify this. Um, yeah,
Yeah, so
I,
I mean, you mentioned it in your talk, but I mean, I guess the sensory changes on the lesions, if they're present, is
hmm,
pretty useful, right? Because not much else does that. But they, as you said, they may not always be present in some forms, and maybe quite minor. Um,
that's yeah, exactly. But if it is present, then definitely that patient needs to be referred somewhere where they can have a proper skin biopsy and be assessed.
and then do you think the distribution helps a bit, like with the cooler body areas classically, or is it a little bit, is that a bit of a misnomer? I mean, I don't know, I haven't seen many cases myself, but
So typically, I mean, that's what we read, right? And that's what we're taught is that, and I think for the tuberculoid cases, the ones, where there are a few lesions, I think um, that's definitely a valuable clinical sign. If you're seeing them on the extremities, face, hands, legs, definitely that helps you. I just don't know if that helps you distinguish it from
mm,
other
yeah,
causes of skin lesions.
yeah, it's true, tough. Um, And then this is just another tough question asking
Mm.
about is a patient on anti-TNF agents susceptible to leprosy as they are with TB, particularly if they didn't receive BCG? I mean, do you know, is anti-TNF therapy a risk factor for leprosy? I'm not sure
No,
myself.
not that I've come across, but it makes sense that it should be. But
Yeah.
but not that I've come across. I think the other issue with leprosy is that, you can have a variety of different immune issues and, still develop leprosy. So like the TNF mediated issues would sort of, I suppose, predispose you uh to sort of more the multibacillary disease. Although nothing's been written about it. I don't know. There are like various case reports, but nothing really stands out.
Yeah, I guess it's not a lot of areas where you get both, that
This
between.
is true.
But
This is also
yeah,
true.
I think I don't know if that's quite what she was asking. Elsie was asking, but I guess it's not like if you're on an anti-TNF agent, you should get a BCG vaccine, for example. That because it's still so rare to get leprosy. Even if you're predisposed to it with various immune deficiencies.
Yeah.
So I mean, who would get the BCG vaccine? I guess for leper. I mean, I guess household contacts, right? Uh,
Right. And I mean, for us, because BCG is part of the,
yeah,
the
yeah.
our routine vaccination schedule, that also might be a reason why we're not seeing it as much. Uh,
Yes,
but
yeah,
these are all just hypotheses.
yeah. Okay. I think that's it. We've got a lot of really interesting questions, which is always a great sign. But yeah, thank you. That's a really nice overview of, again, a difficult topic. Lots of complexity to it. And I think your point is well made, also especially about, seeking help from those people who do see it if you do ever come across these ones. And hopefully we can diagnose a few more, but not too many more. We want to keep leprosy down.
Yeah, having said this, in the middle of COVID, we had a case of lepromatous leprosy at Barra. So these
Oh,
patients are around. I think, and many of them are unfortunately getting diagnosed late. So I think Lucille's right. We're missing them.
yeah.
Thanks, Jeremy.
Cool.